Extract 1, questions 1 to 12. You hear a rheumatologist talking to a patient called Harry Davies, who suffers from gout and is attending for a medication review. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Now, Mr. I understand your GP has referred you to me so that we can review the medications you're taking for your gout.
That's right.
So, tell me a bit about this gout. When did it start?
Well, my first serious attack was last year. My wife and I were on holiday and I woke up one morning with a really bad pain in my left knee. Well, I never thought of gout because I always assumed that just happens somewhere like your big toe, and anyway, I'm only 40. I thought it was something only old people get. So anyway, it was all red and swollen, and I decided it must be an insect bite. But I couldn't think how that might have happened, without me feeling something at the time. Or my wife suggested it might be something to do with the pills I take for my cholesterol.
Unlikely, I think.
But anyway, the pain didn't get any better. In fact, quite the opposite. I started to get frightened because I thought it might be a sign of something really serious. It was excruciating. So my wife thought I needed to get some help. So she phoned the local clinic and told them about my symptoms. They told her to bring me in. It was a good thing she was there. I was in too much pain to drive. I mean, I could only just manage to walk from the house to the car. Anyway, when we got there, the doctor took a look and said he wanted to take a blood sample. He said it might be an emergency because it looked as if it could be septicemia. So then we got really frightened. But about an hour later, they came back and said no, it wasn't, thankfully. But they thought I had gout. So actually, at that stage, we were quite relieved.
Yeah, I can imagine.
And the doctor asked if I'd ever felt anything like it before. Well, actually, then I remembered that in the winter, I play quite a bit of rugby and sometimes I'd get some soreness in the same place the day after, but I just thought I'd sprained it or something, and it would go away after a couple of days. But this pain's much worse, and it comes even when I've been resting. I've had it quite a few times since my first attack.
Right. So, what have you been taking to deal with the pain?
Well, at first the doctor at the clinic suggested I took some anti-inflammatories, but I can't say they made much difference. So when I got the next attack, I was at home, and I went to my GP. She suggested I took... I can't remember the name, something?
Colchicine?
That's the one. So that dealt with the pain better, but it gave me awful diarrhea.
Yeah.
I'd never take it again. And then I had a really bad attack. I think the doctor had got to the stage where, she was already giving me really powerful medicines to no effect. So she gave me liquid morphine to take. It made me feel quite sick, actually. And I was a little bit away with the fairies, walking around not quite knowing where I was.
Right. Did you try any other sort of treatment apart from the medications?
Yes. My GP said I could try using an ice pack, and that did make a bit of difference, but you can't have it on all the time. So anyway, after that, she said, let's try allopurinol, see how you get on with that. So I started taking that, but I didn't get on with it. It gave me a skin rash, so I rang her up and she told me to stop taking it, that I'd better see a specialist. So here I am. Is there anything more you can do?
Well, I'm sure we can find something, maybe a combination.
Extract 2 questions 13 to 24. For questions 13 to 24, complete the notes with word or a short phrase.
Oh, hello, nurse. My husband seems quite settled now, so I can answer those questions if you like.
Yes, Mrs. Georges, now's a good time. Come in and have a seat. So how are you feeling now that Mr. Georges is here with us?
Oh, I know it was the right decision. Being the only carer for my husband has been such hard work, and we did discuss everything fully with the social workers and our doctor. But I do miss having him with me at home. It had to happen, though, and I'm completely worn out.
Do you mind telling me more about your husband?
I do wish you could have seen him before all this happened. He was so active and alert, always helping people. He was in the Navy when he was younger, so he'd often spend months away at a time. I got quite used to being on my own before he retired.
I hope you've got family nearby to help out and keep you company.
Oh, I won't be lonely. Our son lives just round the corner and we have a daughter who comes to visit as often as she can. She has a young family now, though, so she's quite busy. I really lost my husband when his mind started to go.
When did you first notice something was wrong?
Hard to say exactly. I suppose you expect your memory to get worse, so you put the little lapses down as getting older. We all lose our glasses and forget our names. But then it became clear it was more than that. He started to seem muddled, confused by everyday things like making a pot of tea. He would put the tea bags into the kettle instead of in the pot, or the cups, or he'd forget about the kettle altogether and try making tea with cold water.
How was he in himself?
At first he knew something was wrong. He was frustrated and would fly off the handle with me and I'd snap back at him. I suppose I didn't realise he couldn't help it. I feel teary now just talking about it. After 40 years of marriage, we knew what the other was thinking most of the time, but now we can't understand one another at all.
Oh, I'm sorry, Mrs. Georges.
In the beginning, when I really started to suspect something wasn't right, one of the main things he'd do would be ask me the same question again and again. I'd say to him, "Bob, you're driving me mad." And he'd just smile, and the next minute he'd do it again. But now he hardly speaks at all.
How is he with his everyday tasks?
Oh, he has a lot of trouble with dressing. I have to help him. It's as if he's completely forgotten what it is he has to do. Getting him to have a shave is another issue. He won't do it, and he pushes me away if I try to help. I hate to see him looking so untidy. He was always so particular about the way he looked. Maybe you'll have better luck with him than I had.
Perhaps.
Oh, in the last few months he started to wander off during the day. That's been the real problem. He would go out the front door and down the street before I even knew what was happening. I was sure that one day he was going to get hit by a car, and then he stopped knowing the difference between day and night and would get up out of bed at all hours. That really frightened me. I used to wonder what would happen if he turned on the gas for the oven. He was always playing with the controls for it during the day. I'd lay there in bed in the dark, listening to hear if he was going to get up, and then when I finally did fall asleep, any little noise would wake me. That's what finally convinced me to bring him here.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Professor Roland Stalker heads the Vascular Biology Division at the Victor Chang Cardiac Research Institute in Sydney.
Now read the question.
Okay. So, Norman, what we found is that the enzyme in our body that produces bleach, its name is myeloperoxidase. We've known for many years that this is present in coronary lesions that have ruptured.
So let's back up a bit. We produce bleach in our bodies.
That's right. We produce bleach as part of our immune response to kill bacteria and other pathogens.
So the way is we squirt it around our toilet, it gets squirted around our body to kill pathogens.
That's right,
too.
and we have professional enzymes that produce bleach, yeah.
Okay, and the enzyme that manufactures it, if you like, is called myeloperoxidase.
That's right, and this enzyme we have known for a long time is present in coronary arteries that have ruptured and have caused a fatal heart attack. What we haven't really been able to do is to establish a cause and effect relationship between the presence of this bleach-producing enzyme and a plaque rupture.
So what did you do?
So what we have been able to do...
Question 26.
Rebecca Lim is at the Hudson Institute of Medical Research at Monash University.
Now read the question.
Bronchopulmonary dysplasia.
Possibly not stem cells as a broader sense of the word, but what we think is happening is really the placenta with the amniotic sac that surrounds the baby during the course of pregnancy. We know that the human amnion has had, for well over a century now, amazing wound healing effects. So
really?
Oh yeah, absolutely. So
Give me
if you
an
go
example.
back. Yeah, so in 1910, it was a paper that I found trawling through. Do you remember what a library is?
No, sounds familiar.
So I remember presenting this to a group of medical students because they...
Who had never heard of a library before.
Who have never been in the university library, I don't think. So I did a little scan of this article that I found, and it was from 1910. So the use of the human amnion as a biological bandage. And then if you fast forward 100 years, there are still randomized control trial data out there showing that the human amnion is actually far superior to traditional bandages when it comes to wound care for third-degree burns and for skin grafts.
So what's in it? What's in the membrane?
Question 27.
Ewan McPhee is a national leader in rural general practice. He lives and works in Emerald in Queensland.
Now read the question.
My health record?
Well, look, the My Health record in my practice is just, I guess, part of doing normal business, Norman. It's essentially an extension of my clinical record. So with a lot of my patients, I spend a lot of time making sure that my records are accurate, my medication lists are accurate, and your allergies and immunisations. Now, if you take... for example, one of my patients today, she's an elderly lady with multiple medical problems, and look, she pops in and out of hospital a lot. And it's important that, I have an up-to-date summary of what's happening with her, what her medications are, and her results. The results in my practice are available if she ends up in hospital. And she came back from a sudden admission the other day. Basically, she came in without any information from the hospital, but because my health record's linked into the Queensland health system, I actually had the discharge summary there with her medication changes available to me when she came in. So I was able to basically make changes and keep a point of truth for that patient around her health. And, that my health record has become for her.
Question 28. You hear.
The lead author was Lee Hooper, who's on Skype from Norwich Medical School in the UK. Welcome to the Health Report, Lee.
Now read the question.
So we were interested in the heart and the vascular effects. So we were interested in heart attacks and stroke and the sort of combined outcomes around whether we have events or any kind of cardiovascular event, any kind of heart event, and whether we survive them, but also all-cause mortality. So we were looking at death as well and whether they make us fatter and our lipids. So we looked at a whole range of outcomes that we felt were important around omega-3 fats.
So before we get to the heart findings, do they make us fatter?
No.
Well, that's good news at least.
We usually take them in relatively small quantities, so there's not. But they don't make us thinner, but they don't make us fatter either. So we're okay on that one.
So what did you find?
So, primarily we were interested in the actual heart and vascular effects. And basically what we found was they're not harmful, but they're not beneficial either. We see almost no effects. And we had a huge amount of information in the review. There was, as you said, 79 trials. We had over 112,000 people involved in those trials. And all of the people were involved for at least a year.
Question 29. You hear.
Peter Rothwell is Professor of Neurology at the University of Oxford.
Now read the question.
Okay. Well, there have been a few strange observations over the years. So, for example, people had found that in the trials of aspirin, low-dose aspirin, that it seemed to prevent stroke very effectively in women, but not in men, whereas the old trials of high doses of aspirin seemed to work in men, but not women. And so one obvious possible explanation for that was it's just that it's due to body size and that higher doses were needed for larger body size, i.e. men, but lower doses might be effective at lower body size. And so that was one of the clues to just look by body weight and obesity and lean body mass just to see whether the effect did vary.
And you brought together the available studies.
Question 30. You hear us.
Associate Professor Lucinda Burns of the National Drug and Alcohol Research Centre.
Now read the question.
So when you drink alcohol, when you drink a lot of alcohol on a quite frequent basis, we can see the fetal alcohol, which, as you say, is the facial expression of various behavioural things and shortness of the child and other abnormalities. But with cannabis, we don't see those particular visual things, but we do know that there seems to be some behavioural issues that are shown. And the issue then again is, as I mentioned previously, is it is complicated by the other things that go on in the lives of women. So, for example, if they're not eating well and they're drinking, if they might be drinking, they're smoking, it's very hard to tease out the actual effects of the cannabis.
Because I think some of the research has suggested behavioural issues, developmental issues, And if they're exposed to cannabis later on, these same children can have compound side effects from tetrahydrocannabinol. But you're arguing that they're so impure, these studies, you just can't tell.
That's exactly right. And these are exactly the same.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C which fits best, according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear an interview with a scrub nurse called Joanna Swan. You now have 90 seconds to read questions 31 to 36.
Today, I'm talking to Joanna Swan, who works as a scrub nurse in the operating theatre. Joanna, firstly, remind us what a scrub nurse is exactly and where the name comes from.
Sure. Well, perioperative nurse is the correct term, of course, but basically we're all familiar with the notion of scrubbing in. You know, you've seen surgeons doing it. It's not just washing your hands, it's doing that very thorough cleaning to ensure you're completely sterile before you go anywhere near the patient or the surgical instruments.
Mm-hmm.
But the name scrub nurse doesn't quite capture the full role. I mean, basically, your job's to prepare the operating room for surgery. You lay out the instruments, hand them to the surgeon when asked, and you're also responsible for monitoring the patient. So you're like the bridge between the surgical team and everyone else who's supporting the patient.
So how did you first get into this type of nursing?
I remember one of my most formative experiences as a student nurse was shadowing a perioperative nurse in theatre. I had to scrub up too, and I was expected to lend a hand because they didn't want somebody just standing around in the way. It was all new to me, and I was worried how I'd react. I was fine around blood, but I'd never seen a wound being created before. It was a 30-minute hernia op, so nothing special, but it left a deep impression on me. Then later, when I'd reached the stage in my career where I was up for a challenge, that image came back to me.
And what sort of background do you need to go into this kind of nursing?
Well, you can do specialist courses, but I think what's crucial is having a fair amount of nursing experience, particularly in critical care settings. That was true of me, and there's really no substitute for that. To be honest, the job wouldn't suit everybody. The hours can be gruelling and the work's very demanding. You can't just pop out to the bathroom or have a snack when you feel like it. And you're stuck in a small room with some quite strong personalities who are also under pressure. So it's a very intense environment, but also a very rewarding one.
And what skills does it call for?
Well, basically every second counts. You've got to be very efficient and able to think ahead and get things organised. What needs doing immediately, what can wait a few moments, what you need to do now because you might not get the chance later, and so on. I mean, that's the kind of thing you can train somebody for up to a point. But to do it well, you've got to be in the mindset to start with. Attention to detail is crucial. If that's not how you are, then you're not going to be right for the job. You have to be there mentally 100% as well as physically.
And I guess the idea of the team is really important in theatre.
Indeed. It's got to be part of the system. I mean, especially when you're on call, you never know who you're going to be working with. For an operating theatre to run smoothly, there's got to be clear communication and coordination between everyone concerned, because it's the collaboration within the team that keeps patients alive. In my hospital, to promote team spirit, we set great store by meetings. The preoperative briefing, of course, but also meetings to discuss issues and generate new ideas. As a nurse, it's great to feel that your voice counts, and that's not always the case in medicine. So for me, that's a big plus. We also take opportunities to debrief staff after difficult events. I mean, that's crucial too.
And what about the interactions with the patients?
Well, some people have the idea that in the operating theatre you're going to be having just mechanistic interventions on patients who are in no position to respond or interact with the nurse, that you're just providing support to the surgeon and the anaesthetist. But these days, theatre nurses are required to have a holistic, patient-centred approach to care, and this extends beyond the period of the patient's actual surgical experience. Preoperative visitings become the norm, so that patients see a familiar face when they come in for treatment, and this can really reduce stress levels on the day for the patient. For me, this is a really positive development, and I'm always keen to take on that role.
Now look at Extract 2, questions 37 to 42. You hear the monologue of a physician giving a lecture on the types of eczema. You have 90 seconds to read questions 37 to 42. Eczema is not a single health condition. It is a recognizable reaction method seen in a number of skin diseases. Atopic dermatitis is a common cause of eczema that is more prevalent in the patients with asthma and hay fever. The signs and symptoms of eczema include tiny blisters or vesicles that can weep and ooze, eventually producing crusted, thickened plaques of skin. It is always quite itchy. It is significant to distinguish the different causes of eczema, as the effective treatments will also differ. Eczema starts as red, raised, tiny blisters containing a clear fluid atop red, elevated plaques, and when these blisters break, the affected skin starts to weep and ooze. In chronic eczema, the blisters are less prominent and the skin is elevated, thickened, and scaling. There are about 11 distinct types of skin conditions that produce eczema. Atopic dermatitis tends to begin early in life with those with a predisposition to inhalant allergies, but it probably does not have an allergic basis. Characteristically, rashes occur on the cheeks, neck, elbow, and knee creases, and ankles. Irritant dermatitis occurs when the skin is repeatedly exposed to toxic substances or due to excessive washing. Allergic contact dermatitis occurs after repeated exposures to the same allergic substance. The immune recognition system becomes activated at the site of the next exposure and produces a dermatitis. Poison ivy allergy is a good example of allergic contact dermatitis. Stasis dermatitis commonly occurs on the swollen lower legs of patients who have poor blood circulation in the veins of the legs. Fungal infections can produce a pattern similar to many other types of eczema. However, the fungus can be visualized with a scraping under the microscope or grown in culture. Scabies is caused by an infestation by the human itch mite and produces a rash very similar to other forms of eczema. Pompholyx or dyshydriotic eczema is very common and affects the hands and occasionally the feet by creating an itchy rash composed of tiny blisters on the sides of the fingers or toes and palms or soles. Lichen simplex chronicus produces thickened plaques of skin commonly found on the shins and neck. Nummular eczema is a non-specific term for coin-shaped plaques of scaling skin, most often on the lower legs of aged persons. In the xerotic eczema, the skin will crack and ooze due to excessive dryness. Seborrheic dermatitis produces a rash on the scalp, face, ears, and occasionally the mid-chest in adults. In infants, it produces a weepy, oozy rash behind the ears and are often quite extensive, involving the entire body. That is the end of Part C. You now have 2 minutes to check your answers.